So, hello everyone. Today we are going to discuss anatomy questions from KROK Ministry book. So, this topic is very important in anatomy as well as physiology, and it is also very easy to understand. So, let's look at the question number 97. After a patient does not have voluntary movements of the muscles of head and neck. The brain examination with the help of NMR detects the hematoma is in the knee of internal capsule, which conduction tract has been damaged. So first let's look at the very basic terms. So see, if this is a neuron has a cell body, axons and a dendrites. This is one neuron, and there are thousands, probably millions of neurons in your brain. So a collection of neuron bodies would be called as gray matter, and a collection of axons would be called as white matter. So and this term is very basic. It would be used in the brain, cerebellum, or the spinal cord. The gray matter is H shaped in spinal cord. So what do you mean by gray matter? So gray matter simply means there are many cell bodies in that area. Now, but these are they have different terms. They are called different depending on their location. So a collection of neuron bodies in CNS would be called as nuclei, and in PNS it would be called as ganglia. And a collection of axons in CNS would be referred to as tracts, fasciculi, lemniscus, or even capsules. So we'll discuss the internal capsule. And in PNS it would be called as a nerve. So this single unit which you see, it's not a nerve, it's actually a neuron, and collection of axons in the PNS would be called as nerve. So if I ask you what is a ganglia made of, so now you know a ganglia is in peripheral nervous system and it would be a collection of neuron bodies. And similarly, if we say cerebellum has many nuclei, so what do you mean by the word nuclei? Nuclei simply means there are many neuron bodies in that part of cerebellum. So these are the basic terms. So now in that question it was written something like in the knee of internal capsule. So what is internal capsule? Internal capsule is nothing but a white matter. It's a white matter, and in that too, white matter has many fibers: commissural fibers, association fibers, and projection fibers. So this is a projection fibers. What does it mean? That it connects a higher brain center to a lower brain center, and you can see various uh, axons that are passing through these nuclei. So you know what is lentiform nucleus, chordate nucleus. Why it is called nucleus? Because there are many neuron bodies, and since this is in a CNS. So an internal capsule has three main parts: the anterior limb, genu, and the posterior limb. So why it is important to know right now, we'll see later, because different tracts pass through different part of the internal capsule. So let's discuss the tracts. Now you know what are tracts. These are a collection of axons in central nervous system. So there are two types of tracts: the descending and the ascending tracts. In this video we'll discuss the descending tracts. The descending tracts are pyramidal and extrapyramidal. Now why are they called pyramidal? They are called pyramidal because they pass through the pyramids of medulla oblongata. I inserted a picture along with a question actually. So let's see this. This is the anterior view of medulla oblongata. So these are two bulgings you see right here. These. Wait. I'll choose another color. These are the two bulges that are seen on the anterior view and more medially are called the pyramids, and the other two bulges which are more laterally are called the olives. Now you have to keep this in mind because there are different nerves exiting between the pyramid and olive and beyond the olives. So we'll discuss this again in the cranial nerve section. So let's come back to this. The pyramidal tracts are called so because they pass through the pyramids of medulla oblongata. Now, in fact, we'll see that only one of the pyramidal tracts pass through the pyramids of medulla oblongata, and extra means not in pyramidal. So extra pyramidal, they do not pass through the pyramids of medulla oblongata. Now, pyramidal have these are the voluntary. We can the muscles that they are innervating, we can voluntarily control them, but we can't control those muscles which are innervated by the extrapyramidal system. So these are involuntary. And the two main tracts that we'll be discussing in the pyramidal are the corticospinal and also the corticonuclear tracts. So you need to keep in mind these points because these small points are often given in the question, and all these small hints can conclude to a one answer, and we'll see that in this question. But first let's discuss both the tracts, that are the corticospinal and the corticonuclear tract. Okay, so let's first see the corticospinal. Now, as the name suggests, it starts from the cortex and it ends in the spinal cord. So that's why it's called corticospinal tract. So here you can see they are starting from the cortex of the cerebrum. Now, a common thing to both the descending tracts is that they consist of two neurons, a primary neuron and a secondary neuron, often referred to as the primary is often referred to as the upper motor neuron and secondary called the lower motor neuron. And similarly here. So the upper motor neuron starts where? In the cortex of cerebrum. Then it goes down and passes through the pyramids of the medulla oblongata, and then it decussate. Now here they are divided into two. The 90% of the tracts they decussate. Okay, I'll write it here. So the 90% of the tract they decussate at the level of medulla oblongata, where here, and the remaining 10% do not decussate, but they do decussate at the level of synapse. So it's not so all the tracts decussate, that is they cross over to the opposite side. So again let's write it here. So where do they decussate? At the level of medulla oblongata and at the level of synapse with the lower motor neuron. So those which decussate at the medulla oblongata are called the lateral corticospinal tract, and those which decussate at the level of synapse with lower motor neuron are called the anterior corticospinal tract. And the lower motor neuron, it begins in the anterior horn of the spinal cord. Okay, so this is for now the corticospinal tract. Now let's look at the corticonuclear tract. Now again, why is it called corticonuclear? Because it starts from the cortex but it ends at the cranial nerve nuclei. So where does it synapse? It synapse at the nuclei of cranial nerves, which are located in the brain stem. Okay, so let's see. It starts from the cortex. It uh, decussates at the level of synapse and goes to the opposite side. So basically all the tracts, they are decussating. Now why is it important to know the level of decussation? Because it the if there is a lesion at different level, it will produce different symptoms or deficits on different sides of the body, and we will see that later. So let's write it here. The corticonuclear tract, it's the primary is again in the cortex, and it decussates at the level of um, synapse, and the secondary is from the cranial nerve, is basically the cranial nerve nuclei, cranial nerve. So another important difference between these two is that the corticospinal tract, it passes from the in the posterior limb of internal capsule, and the corticonuclear tract passes through the knee, or in Latin it is called the canum of internal capsule. So again, this is the main difference between these two. It passes in the posterior limb of internal capsule. It passes through the knee of internal capsule. It passes through the pyramids. Okay, yeah. So again, this is the main difference that I was talking previously, that not all the pyramidal tracts pass through the pyramids of medulla oblongata. So only the corticospinal tract, it passes through the pyramids. And the corticonuclear tract, it does not pass through the pyramids. Why? Because it will synapse with the nuclei of cranial nerve, right? It's going to synapse with cranial nerve nuclei, and not all the cranial nerve nuclei are present in the medulla oblongatas, the pyramids. They are located at different locations within the brain stem. So clearly the corticonuclear tract will not pass through the pyramids of medulla oblongata, and we'll see that in this question. So this question, the patient's pyramids of medulla oblongata are damaged by tumor growth. As a result, the conduction of impulses of will be impaired in the following pathway. So clearly the answer is what? Corticospinal and not corticonuclear, right? Okay, so let's come back again to this question. Now let's see how many keywords can you find in this question. I have underlined all of them. So first of all, they are saying do not have voluntary movements. So that means there is a problem with the pyramidal tracts, and the muscles of head and neck. So muscles of head mainly include the facial muscles, and that is by the cranial nerve number 7, that is the facial nerve. The muscles of mastication, that is by cranial nerve number 5, and the muscles of neck also mainly by cranial number 5 and 7. So this indicates what? That there may be problem in the corticonuclear tract of the pyramidal tracts. Now another keyword that they have given, it is that the damage is in the knee of internal capsule, knee or the genu of internal capsule. So now it's another hint, and it is also pointing towards what? Corticonuclear tract. So the answer is corticonuclear tract. Okay, so let's discuss it with little more detail. That is when there is damage to the upper motor neuron or the lower motor neuron. So one concept that all of you must know is that the upper motor neuron is basically sending inhibitory impulses to the lower motor neuron. This concept you should know for understanding the consequences of lesion in the upper motor neuron or a lower motor neuron. So upper motor neuron is mainly inhibitory to the lower motor neuron. Okay, so if there is if these inhibitory impulses are not coming to the lower motor neuron, then the lower motor neuron will overfire because it's not being inhibited by the upper motor neuron, right? So when there is an upper motor neuron lesion, there will be increased reflexes. The tone of the muscles, the reflexes will be increased, the tone will be increased, and there will be spasm, or they'll say spastic paralysis, like something like that. And but it will be the opposite in a lower motor neuron lesion. That is, the reflexes will be decreased, the tone will be decreased, because the muscle is not being innervated, right? So there will be atrophy of muscles in both the cases, but in upper motor neuron it will be mainly because of disuse, and in lower motor neuron it will mainly because of absence of innervation. Okay, and since in upper motor neuron lesion we can see spasm, here will be the flaccid paralysis, because the muscle is not being innervated, it will not contract, there will be the flaccid paralysis. So now let's look at this picture. So see, I told you that you have to remember that where the tract will decussate, at what level, because there will be different level of lesion. For example, if there are three level of lesion. Above the medulla, that is above their decussation, below their decussation, and in the upper motor neuron, and in the lower motor neuron. So when there will be a lesion, before their decussation, the defect will be seen on the contralateral side. Okay, I'll maybe highlight it here. On the contralateral side, and when there will be a lesion after their decussation, like right here, like below the medulla oblongata and above the synapse, so there will be ipsilateral weakness, and this is of the upper motor neuron. And when there will be a lesion in the lower motor neuron, there will be ipsilateral paralysis. So we can write this as well, that is above the decussation, that is above the medulla oblongata, the problem or the deficits will be seen as contralateral, and below medulla oblongata and before their synapse, the defects will be ipsilateral, and in the lower motor neuron it will be what? Ipsilateral. So ipsilateral means the same side, and contralateral means the opposite side. And this was this picture, because if the lesion is here, the nerve, this neuron was going to innervate this muscle that was on the opposite side of the body, and it had to decussate in the medulla oblongata, but it did not. So therefore the deficit will be on the contralateral side, and here it has already decussated and it just had to go down and innervate this left side of muscle, so the lesion will be what, ipsilateral, and the same with the lower motor neuron. So this was a basic thing. Now again there's a concept that this is a Babinski sign. So normally if you stroke upwards the plantar side of a foot, the reflex will be that the toes will be flexed downwards. This is a normal plantar response. And if there is a problem with which tract? Corticospinal tract. Remember, we are not talking about the corticonuclear tract. Some will say that Babinski sign is present uh, in the lesion of which tract. They will give you corticonuclear as well as corticospinal. So remember that corticonuclear just stays in your head, that it will just go from cortex to cranial nerve nuclei to just the to the muscle supplying the head and neck or the face and neck. It will not come below the medulla oblongata. It will not enter the spinal cord. So that's why Babinski sign is of the corticospinal tract. Of the corticospinal tract. So yeah, I was showing you the Babinski sign that when there is a lesion in the corticospinal tract, and now when you stroke upwards, the toes will fan out and will turn upwards, and this is called the Babinski sign. And well, this sign is normal in the babies. So because their nervous system is not yet developed, so this sign is positive. But this sign is also positive in upper motor neuron lesion. But it will be negative in what? Lower motor neuron lesion. Now let's see how the KROK people ask this concept. So in this question, there's problem in what? Movements. And the tone is overstrained and spasmodic. These are the key words that you have to look for in the question. The reflexes are strong and also the pathological reflexes are present. Now, what is the most likely development mechanism of hypertension and hyperreflexia? So they have already given that the reflexes are increased, the tones are increased, there is problem with the movements. So what does it mean that there are problem with the movements? That is, they are talking about the pyramidal tract. Whenever they say that there is voluntary problem in voluntary movements, or just they write simple movements, that means they are talking about the pyramidal tracts. And now reading the question, you have to see if they are talking about corticonuclear tract or corticospinal tract. So all these symptoms indicate what? That there is an upper motor neuron lesion. And as I told you that upper motor neurons are mainly inhibitory to the lower motor neuron. So that's why when these inhibitory influences or inhibitory stimulus is decreased, the muscles will be, the reflex of muscles and the tone of muscles will be increased. So this is how this concept was asked in the KROK. Now, since we are talking about the upper motor neuron and lower motor neuron lesion, we'll see a example of upper motor neuron and lower motor neuron lesion in a corticonuclear tract. Okay, so by now you all know that the corticonuclear tract, it starts from the cortex, it goes to the cranial nerve nuclei. And what was nuclei? A collection of neuron bodies, right? And then it will form the peripheral or the cranial nerves. So usually the nuclei, this nuclei has in a bilateral innervation. What does it mean, bilateral innervation? That both the nuclei, that is the left and right nuclei, receive innervation from both sides of cortex. From the both sides of cortex. But there are a few exception, that is cranial nerve number 7, the facial nerve, and cranial nerve number 12, the hypoglossal nerve. So what's this exception? The exception is that in the cranial nerve number 7 has two nucleus, upper and lower. So the upper has bilateral innervation like any other cranial nerve nuclei, but the lower nucleus only receives innervation from the contralateral side. So now let's see what happens. Why do you need to know about this? So they are depicting a facial nerve pathway. So as I told you that it's very faint, that the the purple, that is the upper nucleus, is receiving innervation from both sides of the cortex, this and this. But the lower nucleus, that is the blue one, it is only receiving innervation from the contralateral side. So now what happens? So again, the upper nucleus supplies to the muscles of upper part of face, and the lower nucleus supplies to the muscles of lower part of face. Now you can also think of it as that upper part of face receives innervation from both sides of the cortex, and the lower part of face receives innervation mainly from the contralateral side of the brain. So this is a case of lower motor neuron lesion, and this is a case of upper motor neuron lesion. So now when there's a lower motor neuron lesion, like here, the nerves coming from both the nucleus, they cannot supply to the muscles, so there will be decreased reflexes and decreased tone of the muscles on both parts of face, the upper and lower. But that's not the case with the upper motor neuron lesion. This is the upper motor neuron lesion, and this will only be on one side. Now you know that the upper nucleus receives innervation from both sides of the brain. So if there's a problem in one side, it will still receive the innervation from the other side of the brain. So that means that the upper part of the the muscles in the upper part of the face will still be working, but the lower nucleus, that it only receives innervation from one side of the brain. So if there's a problem in one side, it cannot supply to that muscle. So in the upper motor neuron lesion of the cranial nerve number 7, the deficit will only be seen on the lower part of the face, because the upper nucleus, that is the upper part of the face, will still be receiving stimulus from the other side of the brain. So this is the lower motor neuron lesion of cranial nerve number 7 is called as the Bell's palsy. So in Bell's palsy, both upper and lower part of the muscles of both upper and lower part of the face will not be working. There will be flaccid paralysis. Why flaccid? Because it is a lower motor neuron lesion. And that's it for the video.